Welcome to SLP Nerdcast. I'm Kate.
And I'm Amy, and we appreciate you tuning in. In our podcast, we review and provide commentary on resources, literature, and we discuss issues related to the field of speech-language pathology.
You can use this podcast for ASHA professional development and CEUs. For more information about us and certification maintenance hours, go to our website, www.slpnerdcast.com. SLP Nerdcast is brought to you in part by listeners like you. Even small contributions keep our CEU prices low and our program ad-free. You can contribute on our website by clicking Support Our Work. You can also go to our website to find permanent products, notes, and other handouts. Some items are free, others are not, but everything is always affordable. Visit our website to submit a call for papers to come on the show and present with us. Contact us anytime on Facebook, Instagram, or at info@slpnerdcast.com. We love hearing from our listeners, and we can't wait to learn what you have to teach us.
And just a quick disclaimer, the contents of this episode are not meant to replace clinical advice. SLP Nerdcast, its hosts and guests do not represent or endorse specific products or procedures mentioned during our episodes unless otherwise stated. We are not PhDs, but we do research our material. We do our best to provide a thorough review and a fair representation of each topic that we tackle. With that being said, it's always likely that there's an article that we've missed or another perspective that we haven't shared. If you have something to add to the conversation, please email us. We love to hear from you.
We're so excited to welcome back a guest who's so great, and we're going to learn so much today. We're so excited to welcome Mike Bright. Welcome, Mike.
Hello there.
There's nothing like starting an episode off with a little jingle.
Yeah, that was great.
More singing, please. More singing.
More singing. Let's talk it. Okay.
So, Mike, you're here to discuss childhood apraxia of speech. Before we get started, can you tell us a little bit about yourself?
Sure. I'm a return visitor here, so I'll keep
We're
it.
so excited.
Yeah. But I am a speech pathologist in the Massachusetts, Boston area, and just recently jumped into private practice after working at Boston Children's for almost 15 years. And I have had the honor and opportunity to really focus on working with kids with difficult to understand speech, and particularly kids with motor speech disorders, and had some really strong training through what's now Apraxia kids, and really like to be in that area where I'm trying to pull apart everything in a diagnostic session to really understand what's going on for kids, in why they're hard to understand, and then trying to prioritize with families and service providers what we can do and what should be done before what else, and coming up with a good plan. So I encourage folks to go back and listen to the podcast where I did some talking about the diagnostic process, because I think that'll be important information to have for the conversation we're going to have today.
Well, we're so excited to have you back because we learned so much from you. And for our listeners who haven't yet listened to the other episode, please go check it out. Not to be redundant, but Amy and I came and saw you speak years ago in the Boston area about childhood apraxia of speech. And we learned so much back then. We're learning even more from you now. I know that this is the bulk of your clinical work and something that is like well within your scope of competence and expertise. So we're so excited to welcome you. And before we really jump into it, the powers that be require that I read our learning objectives and disclosures. Learning objective number 1, describe the prevalence of childhood apraxia of speech. Learning objective number 2, describe 3 considerations for target selection for children with childhood apraxia of speech. And learning objective number 3, describe 5 ways to vary speech production practice that supports motor learning. In terms of disclosures, Mike Bright's financial disclosures. Mike is the owner of Bright Speech and Language, LLC. His non-financial disclosures is that he is recognized by Apraxia Kids for advanced training and expertise in childhood apraxia of speech. Kate, that's me. My financial disclosures, I'm the owner and founder of Grandbois Therapy and Consulting, LLC, and co-founder of SLP Nerdcast. My non-financial disclosures, I'm a member of ASHA SIG 12 and serve on the AAC Advisory Group for Massachusetts Advocates for Children. I'm also a member of the Berkshire Association for Behavior Analysis and Therapy, Mass ABA, the Association for Behavior Analysis International, and the corresponding Speech Pathology and Applied Behavior Analysis Special Interest Group.
Amy, that's me. Financial disclosures. I am an employee of a public school system and co-founder of SLP Nerdcast. And 9 financial disclosures. I'm a member of ASHA SIG 12, and I also serve on the AAC Advisory Group for Mass Advocates for Children. Okay, so Mike, we've had a number of listener questions on this topic. Can you start off by just telling us a little bit about the prevalence of CAS?
Sure. I'm glad that we can talk about this because I know last session we talked a little bit about how prominent the diagnosis is. People are talking childhood apraxia of speech a lot, but it turns out that it's actually not that prevalent. And so I just wanted to touch on a few things that go through my mind when I'm trying to hold those two truths. I think it's really hard to know how prevalent childhood apraxia of speech is because of those diagnostic challenges that we discussed. Currently, the gold standard of diagnosis is really having a clinician with some expert level experience make a judgment call. So to have that be the criteria, I think necessarily complicates being able to go out and say there's this many kids with childhood apraxia of speech. It's not the broken bone that you can x-ray and say this many kids have broken their bone this year. But there are some folks who are much smarter than me who have done some estimates that suggest that it's about 1 to 2 children per 1,000 in the general population. And if you kind of zoom in a little bit more to look at the kids who are referred for speech delay of unknown origin, the estimate rises to about 3 or 4%, so 3 or 4 in 100, where children are diagnosed with suspected CAS. So both of those numbers are really low. And there are some groups that have higher incidence of childhood apraxia of speech. Unsurprisingly, boys are 2 to 3 times more likely to have childhood apraxia of speech than girls. And there's also a greater prevalence in various syndromes, such as Fragile X, velocardial facial syndrome, and galactosemia, which is a metabolic disorder. Interestingly, although autism spectrum disorder definitely has a higher prevalence of delayed or disordered speech, research really doesn't support the idea that kids on the autism spectrum have a higher prevalence of CAS. So they wouldn't necessarily, kids with autism wouldn't necessarily be in a group that is expected to be more likely to have childhood apraxia of speech. And yeah.
I have 2 questions.
Yeah.
So I have a fact rolling around in my head from graduate school, and I want to know if it's accurate. And I don't know that this is true anymore, and I have no reference for it. Is it true that childhood apraxia of speech is the most overdiagnosed of the speech sound disorders?
I don't know. And it sounds good. Yeah, I mean,
that's a good answer. If anybody listening has an answer to that, please write in. Because I always carry, when I did work as a general practice speech pathologist, that was always sort of the backdrop is you think it's apraxia, but the prevalence of apraxia, real true apraxia is so low that it's very often overdiagnosed.
I don't know that anyone has been able to kind of map it out in that very precise way. But it makes sense, right? That so many people are talking about it. So many people are kind of dangling it or dropping it into the possibility of what might be going on. This is kind of, again, why I thought it was going to be helpful to touch on what the actual prevalence is. And I think another part that we really talked about that's important to recognize here is that it is rarely, if ever, childhood apraxia of speech in a vacuum. We're talking about kids who almost necessarily have other communication challenges, whether they be linguistic or other.
You answered my second question, by the way. That was going to be my second question about how often does it stand alone and not present itself with a comorbidity?
Yeah, and I don't have a number for you, but I would say from my experience, very rarely. Very rarely, yeah. And so again, I think it's important to have a really strong assessment so that all the variety of communication needs can be mapped out and prioritized, so that if you are saying, hey, I think this might be a childhood apraxia of speech, you've got some evidence to go on, but you're also saying, I think it is something that this child needs to spend therapy time on, or it might be something that that this child works on down the road. But there's some other things that are going to take priority first. So.
And I just want to say, just to piggyback on that, just encouraging our listeners who haven't listened to the other episode about diagnostic criteria, we do unpack that a little bit more. And I think it's a very important point that, in terms of the diagnostic considerations, considering the whole child and all of the other things that are going on is really important.
And I think to put a bit of a bow on this discussion about prevalence, what it does for me when I zoom out like this is it gives me caution when I'm diagnosing. I as a diagnostician should just be aware that all of the kids who come through my office, even though many of the kids are coming through my office because there's some suspicion that it might be apraxia, I need to have this idea of I need to be questioning what else it might be. If it's either something other than childhood apraxia of speech or something in addition to childhood apraxia of speech. So I use the prevalence estimate to kind of keep me in that brain space. But I also think it's important to look at the other side and say, if there's a child sitting in front of you who has been diagnosed with childhood apraxia of speech, and someone has explained to you why that is, either through a well-written report or a conversation, the low prevalence doesn't affect whether this child sitting in front of you does or does not have childhood apraxia of speech. If it's apraxia and someone has decided that this is something that needs to be worked on, I think the low prevalence has nothing to do with that conversation. Does that make sense?
It does. I think it's a really important point. I mean, each client, each student is an individual. It's a beautiful experiment of one, right? So I think keeping that in the back of your mind is a really good point.
Yeah, and I recognize that because the label of apraxia is very prominent, there are probably clinicians listening who have kids on their caseload who they feel like, well, I don't know that this is apraxia, and I think that's a really important question to be continuing to ask. And if someone is not understanding what aspects of a profile really point towards the planning and programming aspects of speech, that be something that is really well understood before you launch into this next part of our discussion, which is going to be talking about how we can implement principles of motor learning into our therapy.
Well, and I think if you're one of those clinicians who's listening and has somebody on your caseload who perhaps came to you with a diagnosis of CAS and you've been treating it using a motor learning approach, if you're not seeing progress, just having that high level of suspicion also would probably be helpful, because it might be time to reassess and step back and take another look.
Yeah, I think that's a great point. And childhood apraxia of speech is something that shifts over time, the way that it presents. I just worked this past week with a friend who I've known for about a year and a half. And when he came to see me at about just after he had his third birthday, I was thinking that it might be apraxia. And he came back in 6 months, and I felt more confident that it was apraxia. And now, almost a year later, I still feel like he has childhood apraxia of speech, but if it was the first time that I saw him and he had those abilities, I would be saying, I don't know, like maybe not. But kids kind of depend, especially if they've been getting good treatment, these symptoms of planning and programming difficulty are hopefully going to become less overt. So it is really tricky, and hopefully something that people can be kind of puzzling about and thinking through, rather than just chucking it in the trash and saying, I don't think there's any validity here, and let's just work on the thing that I feel most comfortable working with.
So thinking about that clinician who may be treating someone who there may be somewhere in the middle of that road. Well, maybe it's apraxia, X, Y, and Z, thinking about the whole child and all of the different components that go into the diagnostic considerations. I mean, I have to assume that there's a link to those considerations and treatment, right? I'm sort of like thinking ahead into that second learning objective about what you do next, right? So
Yeah.
the childhood apraxia of speech, to me, you said it so well before, you're not going to go to the doctor and see a broken bone. Well, there it is, black and white, right? It's such a messy ball of consideration and gray, especially when you're talking about these other, that it's so often seen with other diagnoses and other issues. So I have to assume that choosing a treatment, but I guess this is a question, is choosing a treatment plan often as difficult or as complicated?
Yes, except I feel like it follows naturally. If you've done a thorough assessment, and you feel strong enough to say, yes, I think this is a childhood apraxia of speech, and I think that motor speech planning and programming is something that needs support because of X, Y, Z. It's really that X, Y, and Z that you're incorporating into your treatment plan so that becomes the focus. For example, if a child is having some disrupted co-articulatory transitions where the voice is not constant throughout an utterance, that is going to be a focus of your treatment no matter what speech movement you're working on. Does that answer your question?
No, it does. And as a matter of fact, as you were answering my question, I thought, well, that was sort of a dumb question because it mirrors so much of what we do in so many other aspects of speech and language, so it makes it.
Yeah, no, that's the hope. And I think I think it's also a good point to stop and say that I feel like it's perfectly appropriate to diagnose suspected childhood apraxia of speech and to put that little disclaimer and revisit after you've had a chance to really dive deep and do some of this therapy. It almost becomes like diagnostic therapy, where you are getting into some of the things that we'll talk about and you see, how does this child respond? And maybe she responds in a way that you're saying, ooh, maybe it's not apraxia. Maybe this is looking a lot more phonological. Or you're seeing some generalization from things that you really haven't worked on. And not to say that phonology can't develop while you're doing motor speech therapy, but if you're seeing these gains and suddenly you get a different child in front of you, it gives you information to reconsider. And let me be the first one to say I have been wrong about diagnoses, and I am happy to admit that and feel like we should be constantly trying to do what's best for these kids, whether that means it's called this or this. So that's kind of where I'm starting from. But before we get into what do we do? So what, right? So we think that this is an area that needs work. I think before we even start the therapy, there needs to be some real focus on target selection. When we're choosing our targets, what are we working on within speech therapy? We're treating movement. We're not treating sounds. And that's a biggie.
That's a biggie. That's a real biggie.
Yeah, it's a real biggie because it's different.
Right.
And so I guess you might think about it in the way that non-speech motor tasks don't translate to spoken language. It would be the same thing here. Targeting how to articulate a specific sound does not translate into how you're able to move between that and other sounds.
And that can be so hard for families to understand too.
I was just about to say that.
You know, that's a piece where I think that people's picture in their mind of traditional speech therapies, you work on the sounds and you work on the sounds in isolation, and then you work on the sounds in syllables, then you work on the sounds and that's really different. I didn't know if you had some helpful ways that maybe you've used to explain that. Have you encountered that, or is that
helpful ways to explain it? I guess I want to make sure that we're not saying that you can't work on articulation with a child who has childhood apraxia of speech. A child does need support in knowing how to form sounds. But I guess I would put that in this kind of pre-practice area before we're doing the motor learning aspect of this therapy. There's some pre-practice. You need to know what you're doing with your lips. You need to know what you're doing with your voice. Is it on? Is it off? But we're not in therapy going bah, 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 popping our lips for I don't know what reason. We're not doing that. We want to be somehow incorporating. I mean, bah, as I did that, I did make it into a syllable. So maybe we are doing that, but we're that's a better example. Not just popping on a P to kind of get our lips moving or something like that. We really want to be incorporating it into a movement. So how do you write about that if you have to put it into a goal for your IEP? That is just a little bit of a different way to do probably what folks are already very comfortable doing. You want to establish the parameters of the movement that you're targeting. You want to define the support that you're providing the child, and then you want to just make sure that the goal is measurable so that you know if this child is doing it or not. So for example, you might say, Sarah will produce 4 single syllable words containing accurate movement between p, b, d, e, u, and I with 100% consistency in direct imitation across 3 consecutive sessions. So
that goal.
What's
I don't
that?
know why. I love that goal. It was just very specific and very measurable. And I think for me as a clinician who is not as familiar with or comfortable with childhood apraxia of speech, it surprised me to hear that it was the coordination between the sounds and not specific movement. So I have the materials in my head, right? I'm looking at that flip book, the book, everybody knows what I'm talking about, right? Where you flip the things and it says bee, boo, ba, boo, bee, well, I just said an interesting word, but you know, you know what I'm saying? And in my mind, it would be, you're working on front sounds to middle sounds to back sounds to front sounds. And it's like the movement between them instead of just any coordination between the sounds themselves. Am I articulating myself well? Am I having a communication disorder? Did that make any sense?
Let me tell you what I understood, and then you can let me know what I missed.
It's okay.
So there's a program called Moving Across Syllables, which is very structured around moving between different points of articulation, like front sounds to back sounds. And then you get a page of 16 pictures where that's the movement that's being asked.
That's what I think of.
Yeah.
When I think of this kind of treatment approach.
Right. And I guess this is a good time for me to say what I'm hoping to do when I'm going through both target selection and some of these principles of motor learning is just to lay out some basic foundations for where kids might be starting. Because I feel like if you understand where to start and you understand how to make things either from where to start, if you understand how to make things more challenging, you can do a lot of that expansion. But I think it's sometimes harder when you are working with kids who are pretty impaired and you're giving them this wide range of movement that is beyond their current capacities. How do you work on motor speech with those friends?
I wonder if you can talk a little bit more about that piece right there, and I'm sure you will. But in thinking about, I feel like now I'm going to go back to grad school, which was also a long time ago, and this may be wrong. But I remember thinking, hearing about, especially for those clients who have a pretty limited repertoire, maybe to contrast it with something like moving across syllables, which is sort of a pre-made curriculum. Like you may pick, they called it like the personal core, and just picking words that were important and meaningful for that person. Is that still a thing? Is that a thing that you would do?
For me, it is. I think that definitely when I'm considering what target to be picking, I would love for it to be something functional. I would love for it to be something motivating. I would love for it to be something that I can design therapy activities around. There is we're getting a little bit ahead of ourselves, but there is that's okay. There's an Apraxia approach called REST, rapid syllable transition, that actually uses non-words. So and focuses on really on this movement aspect and getting prosody to be just right. And it's been shown to be effective. So I'm not saying that you have to do these functional speech movements, but I'm also feeling like if I can, why not? Why not give someone that leg up? So yeah, and we'll get into a little bit more down the road. So definitely circle back if I don't give you the information that you're hoping for.
So tell us a little bit more about this second learning objectives, because I feel like my question derailed your brilliance, because you were about to expand on that, and then I interrupted you.
Yeah, what the heck? What the next idea? So we've got this idea of working on movement, not sounds. And the next point that I wanted to make is that when you're selecting which speech movement to focus on, you really want to think closely about what is already in the child's independent phonetic and phonotactic inventories. Which new sound combinations or which new movements are likely the easiest to achieve? Or how might you choose a target that increases the difficulty by varying those parameters a little bit?
And can I just take you all the way back to like undergrad and have you remind me and our listeners the difference between phonetic and phonotactic?
Sure.
I don't know what phonotactic is, so you can tell me.
Sounds and syllables. So you want to know what sounds a child is producing, and you want to know what word shapes they are producing. Is it like many young children, exclusively open syllables, where there's consonant vowel and consonant vowel, but there's no closed syllables? How many syllables is this child stringing together? But there are ways to think about movement sequences when selecting these practice targets that make the movement either easier or more challenging. For example, if a child was working on moving from that D sound, I might choose the syllable D before I chose the syllable da. Even though da might be more functional because you can talk about dad, D, I would suspect, is an easier movement for this child to produce because the D and the E are somewhat homoorganic. They come from nearer to each other within the mouth. So it's funny to think about sounds living in certain spaces, as I can see. Maybe
no
that's
one can see my eyes getting really wide. I'm like, wait a minute.
Aren't you picturing that diagram from grad school where all the sounds are?
Your vowel quadrilateral.
I'm thinking about the diagram and realizing how little I know off the top of my head about that diagram because I don't interact with that diagram very often.
And let me take the worry out of it, because you can figure it out by saying these syllables yourself. D versus da. There's jaw grating when you're going into that low front ah sound. You have to open your mouth in a way that you don't when you're producing D.
You're right.
I know, right. Nice.
I'm sitting here just like moving my mouth. No, you're right. That makes a lot of sense.
So
because it's movement, not sound.
Exactly. So it's just something to consider. And that doesn't mean that every child out there is going to have an easier time with D than da. It doesn't work that way. Some kids might have an easier time with da for some reason, but it's where I would start. If I was working on trying to establish these targets, my guess would be we would do D before da. Similarly, I would want to be using a monophthong rather than a diphthong as my vowel. So a monophthong is a vowel that is just an isolated movement. A diphthong is one that has movement between different sounds.
Just to defend myself, I knew what those were.
Fair enough. I wasn't going to say anything. I thought it would be helpful. So A, O, I, ow, oi are the diphthongs, those vowels that have movement. I would expect something like D, or even something like da, which I just said is more difficult likely than D. I would expect da to be more easily achieved than die or dow or even do.
Because it's more movement. When you look at it through the lens of movement, it makes so much sense.
Nice. And I think that's a great thing for us to keep coming back to. We want to be thinking about movement. There is also something that I think is important to think about when thinking about a child's inventories. And it's that when you're teaching new sounds, you want to be, and sorry, I just said you're teaching new sounds when I previously said you're teaching movement, not sounds. When you're trying to introduce a new sound movement sequence, you want to be using that less familiar sound in a mastered syllable shape or in a mastered word shape. When you're teaching a new word shape or a new syllable shape, you want to be using mastered sounds. So I hope that makes sense. But basically, with kids, when there really is a core impairment in planning and programming speech sounds, we want to be able to really think about how can we make this process as smooth as possible, as easy as possible, without heaping on these extra layers of challenge. We can expect that if a child has open syllables, like a CV syllable, but not a closed syllable, that if we're trying to introduce a new movement from a sound, we want to do that in that open syllable rather than the closed syllable. Even though we might have another goal, which is that the child should close syllables. Let me see if I can do an example. Let's see, a friend who is using a t, but not a p, and has exclusively open syllables. If movement from a new consonant, if movement from that p is the goal, I want to do it in a word like p rather than a word like up, because that p is going to be easier for this child to move through when using a syllable that is in his inventory. If the goal is targeting a closed syllable, I would want to work on something like eat rather than up, because that t is something that's more firmly established. So I want to be selecting one or the other, a new movement from a sound or trying to expand and strengthen the ability to use a sound in a new place.
Can I say that back to you?
Yes.
Tell me if I'm wrong, because I might be wrong. But when you're thinking about somebody who has limited sounds in their repertoire and has limited word shapes or syllable shapes in their repertoire, you never want to work on two hard things at once.
Nailed it. Yep.
Boom.
That's
All
it.
right. Nice job.
Yeah.
Schooling us.
Because
I have a question. Oh, sorry. Go ahead.
Yeah.
No, go.
Well, I was just going to say, I mean, I think what this points to is this is an approach that is going to be especially effective for a very select population, a very I would venture to say an unusual set of circumstances has made it such that a child needs this type of breakdown. Most kids don't need this. Most kids just kind of sponge it in, and maybe they need help to learn a new sound and how to produce it. But they really don't need you to think about what vowel you're pairing with it, because movement isn't the problem for most kids. They're trying to expand their sound system, and for some reason that isn't going as well. But when a child really has this core impairment, what you will find is that the more work you can do up front to think about these different speech movements that you're asking, the more kind of wiggle room you have to do that dance where you're trying to push a child just a little bit, but not too much where she falls flat and can't do it.
I have a question. Of
Yeah.
course, I have a question. So when you are doing this analysis, you've gone through this. I'm just going all the way back to the beginning and thinking about the whole process. So you've gone through the diagnostic considerations. You feel like, hey, maybe this is apraxia because of the things that you see. You do your analysis and you're choosing your targets using all of these components. When you go to choose a treatment, like an actual intervention, what is the role of some of these pre-made moving across syllables, Kaufman cards? I mean, I think I see a lot of people, I run into a lot of students in my consultative work who carry this quote diagnosis, and the team's just using Kaufman cards because that's what you use when you see a diagnosis of apraxia. So when you really get into the analysis, where do these structured interventions, like what role do they play?
That is another really good question. And I think it's probably good for me to pull back the curtain and just show some of my bias. I am someone who really feels strongly about an eclectic approach that draws from a lot of different programs. I feel like it is, it would, again, be very unusual if you had a child sitting in front of you who needed to work on exactly what Kaufman set 3 has in it. I think those Kaufman cards can be helpful. And again, this is me personal. I feel like you could go dip into that Kaufman card deck to find the P card because you're working on P, and great, there's somebody peeing in a potty, and you can use that picture. But
I was thinking about the vegetable, but that's fine.
But I guess what I would say is I almost prefer to go, well, not for P, but I prefer to go to Google image search and find my own pictures that might be relevant to a kid's interest and might be exciting, and then print them out on a color printer and then be able to give them to the family and kind of go that route. I think maybe for older or more speech able children, there can be some benefit from especially the multisyllabic targets there. But again, like I have no reason to work on potato if a kid is interested in Pokemon. Let's talk about Pokemon. Different Pokemon, those words are ridiculous. And they're great speech prompts. So I don't know, maybe
I'm like so tempted to go Pika, but I won't. But I did. But that makes a lot of sense. I mean, I feel like that mirrors so much of our clinical decision making, where one size fits all is not a thing. Treatment always does need to be customized, and just because something is published doesn't necessarily mean that it's the right fit in its entire package.
Yeah, and just again, the last note that I'll add is I understand why someone wants to pull out the Kaufman cards or do moving across syllables when when someone doesn't have the more full understanding of what we're trying to work on and what we're trying to accomplish. To have a program that has been quote unquote approved for childhood apraxia of speech, whether there's research behind it or not, it is, I think, reassuring. But hopefully what we're talking about is really understanding in this next section, which we're going to have to jam through, is talking about some of these principles of motor learning that you can put into any kinds of speech therapy. Before
That's
I get
a great segue.
Yeah, thanks. And I'm going to mess it up now because I wanted to talk about one more thing. When you're talking about, and I'll do this quickly, when you're doing target selection, especially with kids who are more impaired, you want to select a very small set of movements. We're talking about 2, 3, maybe 4, and you're trying to structure your session around those. And if you go back to our diagnostic podcast, it's that image of the scarecrow in the cornfield. You want to be moving accurately, efficiently through these speech gestures again and again and again, so that you are making those easier to access. Again, a reason to really think carefully about target selection and to make that a part of your practice that does take a little bit of time up front, but hopefully makes the progress and the progression much easier to see. So let me get to these principles of motor learning. What does that mean? It's something that's taken from the non-speech motor learning literature and has been applied to speech. Also, to some degree, it's taken from work that folks have done on acquired apraxia of speech, working with adults who have an acquired apraxia, and then trying to use those principles with children. There's more and more studies. They're not great, but there's more of them out there that have confirmed to varying degrees that these principles of motor learning that we're going to go through do impact motor speech learning for kids. And it's clear that there's more research that's needed to see and identify which one of these conditions or which one of these ingredients that we're going to talk about modifying is going to really maximize improvement for kids with apraxia. But it is clear that these principles of motor learning are going to be key in the treatment of speech for these kids. So we touched on it quickly before, but before you even can do this motor speech learning, there's some precursors that you need. There's some things that need to come before. Maybe it's establishing how to produce a sound. That's going to be before the motor learning practice. You also need kids who are motivated, and you need kids who have the ability to sustain some attention or to have some shared attention, where kids are able to receive your cueing and adjust their productions accordingly. And you can totally have goals in that area. You can totally have goals for kids who you want to be working on their motor speech skills, but they just don't have some of these I don't want to use the word precursors again. Don't have these kind of foundations to do the practice. And going back to that DEMS assessment that we talked about in our last podcast, that's a great one because it really does model some of the demands that would be made of a child who's doing some of this motor speech practice. Once these precursors are established, we really want to focus on our cueing techniques to promote accurate movement gestures. It's going to be multimodal. We're going to use tactile, visual, auditory, proprioceptive cues. It's a lot of listen to me, watch me, feel the movement. We are going to be doing what Edie Strand refers to as a continuous shaping of the movement gesture. We are getting in there with our hands and with our auditory models and with our visual models, and we are trying to see what we're able to do starting with maximal support. How can we enhance a child's speech skills? And then how can we pull back to place increasingly greater demands on the child to do these motor speech actions more independently? So the maximum support that you can give a kid is a simultaneous production. It's sometimes called choral production. You are saying this movement as the child says it. The child has the ability to hear it and see it, and maybe even you're providing some tactile cues as well to help the child move through that movement. You're probably doing it with an elongated or slowed down vowel, so that it's a little bit slower at first. And then the idea is that you're shaping through these tiny steps, through these small adjustments that we're going to be talking about, fading or adding support within this hierarchy, and asking, either providing more support for the child or stepping back to ask the child to do more independently. Basically, what I've got, I'll go through a quick hierarchy of cues. But if folks want to go on the internet and type in integral stimulation, that's the foundation that this is based on.
We'll put a link in the show notes.
Okay. It that was developed for adults, but there's another program called DTTC, Dynamic Temporal and Tactile Cueing, and that was modified. That was basically integral stimulation for kids. But we're starting with choral productions. We're using full gesture and touch cues. We're modifying our rate, prolonging vowels at first, and then moving towards natural normal rate. And we're fading the clinician's model, first by decreasing loudness, so that you become less and less loud, while the child is speaking at normal loudness. And eventually you're just miming, you're showing the movement, but you're not giving any auditory model. From then you're moving to direct imitation, where you say it, the child says it. From there, you're going to move to introducing a delay, a 1 or 2 second delay from the model. And then after that, you're hopefully encouraging spontaneous production. So it's kind of like a ladder, right? You're going up and down the ladder based on what a child needs. Within each practice session, you're jumping between different rungs on the ladder, depending on what a child needs, but you're trying to, again, hit this sweet spot in your dance of the point where a child is accurate, is consistent, and is as independent as possible.
I have a question about tactile cues. So I remember learning a handful of them, on the job from my CF supervisor because I didn't know what I was doing. Are there standard tactile cues that a clinician can and should use, or are we getting into like the prompt certification prompt hierarchy? If anybody doesn't know what prompt is, it's all caps PROMPT, and it's a structured training procedure for apraxia. Isn't that right?
A couple things. I feel like I use my own touch cues, my own tactile cues. I've done the first, whatever you call it, for prompt, the 3-day session. It's similar in many ways to what I do. I also don't follow it to the letter. I feel like that's another tool that I have in my kit, but I know other people swear by it. So I feel like as long as you're doing something that is consistent session to session for a child, and extending that, as long as it's consistent with what another provider might be also doing with the child, so that if outpatient and school clinicians are working on the same speech movement, hopefully, you're using the same you're using the same verbal cues, you're using the same tactile cues, so that the child is getting the same input rather than getting kind of two different, possibly confusing messages. When I am doing speech therapy with kids working on this type of thing, I want to be doing repetitive drills. I want to be as playfully and as fun as I can make it. I want to either introduce fun activity, and then we're going to do some drill play where you say this thing 10 times and then we launch that balloon across the room. We're going to we're going to make a road across my room. And each time you say the thing, I'm going to put the card down. And then eventually we're going to connect the road to the other side of the room. And we're driving across that whole road. But in that activity, saying something again and again and again. I love jumping activities because kids love to jump and they love to move, and it gives us a chance to get out from the table. I have invented a therapy child named Joe, who is magically always 1 year older than the child I'm seeing, and it is always a really good jumper. And I see if this child who's there to see me can beat Joe. And we often have a ongoing competition between whoever's in the room and Joe. But giving a child, so why is jumping important? Because you're going to put down how many things you can jump over. And each time you jump over 2, you say it twice. You jump over 3, you say that 3 times. By the time you get to 10, there's that many productions that you've just done. I use games, especially if they're quick and they provide lots of opportunities for us to do our trials. I'll even roll dice with kids where I've got this a printout of dice 1, 2, 3, 4, 5, and 6, and we just see who can roll all the numbers first. It's a little bit brain numbing, but it does get some kids motivated, especially if they've got a marker and they can cross it off. And then each time you roll the 5, you say it 5 times. I'll even hold a pen in my hand and I'll try to have a child say whatever the target is, and I count on my fingers. And then by the time I've gotten to 5, I've dropped the pen, and it's you made me drop my pen again, or whatever that might be.
I just want to point out really quick how unique this is, because I feel like in speech therapy, particularly with kids, we try and stay away from mass trials but it's a fundamental component of motor learning, it sounds like. So maybe an exception to the rule in terms of, making therapy fun. In other words, trials can be productive and fun and not robotic.
Yeah, because if they're robotic, the kid's going to run screaming from your room. Right. But also it's as if you had my notes. The next thing that I wanted to talk about is the difference between massed and distributed practice. When we're talking about mass practice, we want to be using the same movement sequence again and again and again across our whole session. As opposed to distributed practice, where we're trying to practice one speech movement, and then we're going to switch to another one. And then maybe we'll circle back to the first one. When we're trying to establish a new skill or a new movement gesture, we want to be using massed practice. When we want to encourage generalization, we want to start distributing that production either throughout a session or even throughout a day. For example, if I wanted to be working on the syllable B, the movement B, with a child, and I wanted to do massed practice because this was something that's new for her, I might have a structured tabletop game where there's a bunch of papers and we look under each one to try to find the B. And we're saying B, B, B each time we flip it over. Then maybe we go for a movement break and we jump over a bunch of letter B's, because why not have some literacy in there too? And then we might have a third activity, which is we're playing a game like Honeybee Tree, which gives lots of opportunities during the setup as well as the play for us to be saying things again and again and again. If we wanted to do B, but in a more distributed context, maybe we're using an activity that focuses on B, followed by one that focuses on up, a different speech movement. And then, like I mentioned, we might even, if we want to distribute B further, we can talk about providing other caregivers or other educators with this word and say, hey, see if you can sneak in a few B's throughout the day. That's another way to distribute the practice. The next practice variable that I wanted to propose in this area of the principles of motor learning is the idea of, and it's related, it's constant practice versus variable practice. So you're either practicing the same movement, B, or I guess a better example might be if a child is putting some words together, my B, my B, my B. They're finding it and they're saying it's my B, versus saying something that's more variable. Maybe there's a picture of a bee and then there's a picture of the mom and it's my bee, my ma, my bee, my ma. That would be a variable practice. And again, the constant practice would be one that we'd be using for kids as they're learning a movement, and we'd want to make the practice more variable as we're trying to push for generalization. I think that this is a particularly important consideration to push for more variable practice, because we want to be providing the child with practice moving between lots of different speech sounds. And it is a pathway that we're trying to establish, but we want it to be flexible enough that it can be applied in any way. So maybe if we wanted to make it more varied, we might either vary the carrier, my B, your B, my B, your B, or maybe we'd do it like I said before with the my ma, my B, my ma. I know we're kind of running short on time, so let me try to shove these last few into the podcast. You want to be thinking about the feedback type that you're providing children. There's something called knowledge of performance, and that contrasts with knowledge of results. Knowledge of performance is feedback that speaks to the child's movement. Something like, wow, you really popped your lips there. Knowledge of results is feedback that speaks to the child's accuracy, saying, nice, way to go, you nailed it. Knowledge of performance, saying things like you really popped your lips, is good for learning. The knowledge of results is a way to pull back and encourage generalization. Similarly, the feedback frequency, how often you're giving a child feedback, can influence the motor learning. If you're giving feedback immediately, it is providing less opportunity for the child system to know whether it is accurate or not, which can be helpful, but it also can detract from the ability to generalize. So we want to move from immediate feedback to more delayed feedback, to even after a block of practice, have a child say something 5 times and say, hey, you got 4 out of 5. So for those 5 trials, there's no feedback. And the child is maybe, hopefully, starting to monitor. It's really hard for kids, at least the kids that I work with, to learn to listen to their own productions, especially when we are so quick to be excited and jump right on with our feedback. But anything that we can do to increase self-monitoring is huge. The power of self-correction is just like, I don't know. I freak out and do a little happy dance whenever a child in my session self-corrects. And I make sure that all the providers that are working with this kid and the family knows, hey, when Johnny fixes his production up, I want you all to get so excited. I'm almost more excited by self-correction than I am by a child being accurate, because it shows that there is listening and that there's monitoring and there's modifying. All of these things that kids are going to need to be their own speech pathologist. So feedback frequency can be a variable that you modify to when you're thinking about those things as well. The last thing that I'm going to fast forward through is the prosodic demands. So varying rate, intonation, and stress. Once a child exhibits accuracy with a specific speech movement, I want to challenge her system to change the intonation and the stress. Sometimes with young children, it's as simple as saying, hey, let's say it like Elmo. Hey, let's say it like Cookie Monster. Let's do it like Mom. Let's do it like a baby. But basically what we're doing is we're doing the same speech movement gesture, but we're altering some of those suprasegmental features that require coordination. And what we want to be able to do is maintain the accuracy of the speech movement while adding some of those other features. With older kids, I might say, hey, let's do it like we're mad. Hey, let's do it like we're scared. Let's do it like we're sad. I'll model all those things. And kids can have some fun with that as well. With even older kids, I might try to incorporate some linguistic elements like, hey, let's do that like we're asking a question. And in that, what we're doing is we are, again, we're practicing the movement, but we're trying to make it as flexible as possible. Typically, rate is a good one to vary, with productions being slowest at first and then becoming more fast as children become more able. And we always want to be working towards this idea of automaticity, children being able to move through these sequences more automatically. So I'll say things like, hey, can we fast forward that one? Can we try to get that movement to be accurate while we're going more quickly? So there's so many things that we haven't talked about. And I think what it points to is, I guess what I'd like to say before wrapping up is if we're thinking about practice schedule, feedback type, prosodic features, it's overwhelming, right? There's too much to be thinking about to then be in front of a child and be any fun at all. So it's an understanding of these skills, an understanding of how they might be modified, so that when you're in the session and things aren't going well, you know how to make it easier. If you're in the session and, oh man, this kid isn't even being challenged, you know how to make it a little bit harder. Again, you're thinking about the movement and ways to either support or challenge that.
That was a tremendous amount of information. I can't believe that all of this like lives in your head. You were just so fluent with all of these. That was like brain explosion one after another. It was so incredibly thorough and helpful.
Yeah, well, I'm glad that you said that. I do feel like I really rushed through that and would understand if people heard that and felt overwhelmed. So there's plenty of good information out there that kind of outlines all of these things. But I think the best thing that you might be able to do is pick one of these variables and try it out and see how it affects the kids that you're working with. And then maybe when you get comfortable with that, add another one.
And to anyone who is listening who feels overwhelmed or feels that was a lot, a dense clip of information, we are going to have a handout available in the show notes where you can read, digest. I'm hoping that a lot of listeners who have experience with apraxia already, who are taking this or listening to this episode or taking this course to do a little bit of a deeper dive, are feeling a little bit more comfortable. But that handout is also available to you. Is there anything any more brilliance you want to share with everyone before we wrap up?
No, I don't want to. I haven't put my foot in my mouth yet, so
okay, good.
I feel like it's a trap.
Well, high note. If anyone has any questions for Mike, his contact information, he's been very generous and agreed for us to list his contact information on our site. It should be available in the show notes if you have questions. You're a super nice guy. I know you're going to write back to anybody who emails you with questions. I think that's probably obvious. So don't hesitate to reach out to any of us if there are things that you would are seeking clarification on, or additional questions that you have. You can obviously use this episode for ASHA CEUs. And if you have any questions about that, feel free to email us to get CEUs, cruise on over to our website, purchase the quiz and take it. And your information, if you pass with a score of 80% or higher, your information will be sent over to ASHA and you'll get a certificate and all that jazz. And Mike, just thank you so much for joining us. This was really, really wonderful.
So good.
Thank you guys so much. And really, I guess what I will wrap on is I appreciate that you all are doing this and that you're motivated to try to get this information from my brain out there and from other brains out there, because it's too much for any brain to know all of this stuff. So the more that we can share this and the more that we can feel okay about not knowing and asking questions and not having to pay out the nose to get the information, I think the better. So I really appreciate that you folks are doing this.
Well, we appreciate you so much.
Yes, it's made possible by generous people like you giving your wisdom and time. So thanks to everybody who's listening, and we hope to hear from you soon.